So this is going to cross boundaries between radiology and neonatology, hopefully, and it's going to be pretty clinically orientated because I think that was what people wanted. So I can start with you right in the front row here and say you've just admitted this 41-week term infant with APGAR scores of 1, 3 and 6. She remains quiet over the first 12 hours of life but is not requiring ventilatory support. Would you, one, order a cranial ultrasound of her? You have to say what you would have done before today, before hearing me rave about cranial. And if so, when would you order it? You're allowed to be completely honest.
At 12 hours, probably I wouldn't. I would wait.
Till?
I would want to see her the day after and see what the course is. 12 hours would be a little bit early for me, and I wouldn't get it at 12 hours.
Actually, it depends on the hour in the day that she was born.
As to whether there is a technical...
I would like to know, sorry, I would also like to know the first guess.
Okay, so her first gas had a pH of 7.01 with a base deficit of -14.
So I would be more happy to get so it's not enough. The clinical data is not enough. You need to get a little bit more lab data.
And the history.
Yeah, for sure.
The background.
And her exam.
Just before, bradycardias or meconium, thick meconium, any evidence of fetal miscarriage.
So would anyone not get a cranial ultrasound here? Would anyone feel that a cranial ultrasound was useless? Why are we getting a cranial ultrasound?
Because it's the most
available
tool that
bedside.
we have. Sometimes we are doing it by ourselves,
Yeah.
without waiting to the radiologist.
So you would not?
I don't see any indication at this time for the time being to do ultrasound. The child, like, you don't have any indication. You don't have any clinical encephalopathy, any clinical. You say about pH, which we see it many times. If your child is healthy, his physical examination is okay. I don't see any indication like to do ultrasound or further.
So what you know is that her APGAR scores were low.
What does it mean? Remain quiet.
Right, she remains quiet. So I haven't told you much about that one. But these are kind of some of the terms that I hear quite often is, oh, she's just quiet. Or the other thing, like a lot of the staff I'll hear say is, she's just recovering from your resuscitation. And I'm like, well, what does that mean? She's recovering. Like, that means she's recovering from something, right? So the whole point of understanding risk is that you identify there was a risk and there's an altered state somehow. The reason to get a cranial ultrasound for me isn't because you'll be able to diagnose an ischemic brain injury, but you may be able to look for whether there is any other blood or whether there is any other etiology of her needing assistance around the time of delivery. So being born is a stress test in a way, right? It's a very stressful thing to be born, and if you don't do it well, is there a reason you don't do it well? And
10% of the children they don't.
but she had these, and she remains quiet, right? So she is not completely healthy in terms of being vigorous and reassuring. So of course more history and details of the exam, but you know what the data from those 4,000 babies showed us is that even when babies are stuporose or comatose, and we think like every baby that went into the Vermont Oxford, people thought had hypoxic ischemic injury. That was what the registry was called, right? But 4% of them had some other form of dysgenesis identified on cranial ultrasound. So it's not high, but it's real that there may be some other underlying reason why they didn't transition well.
The slit ventricles, something that we translate as brain edema. We found it, is it useful?
Right. So, yeah, it's notable depending on the history and the clinical exam. People who have done studies in the well baby nursery say that up to a third of healthy, so-called healthy babies have slit-like ventricles. I don't know how healthy all of those babies were, but maybe it is not a completely reliable sign because some babies will have very slim The ones that worry me the most are when you can't see any CSF anywhere. So if the occipital region in particular is being ablated, as well as the frontal horns, as well as the temporal, in other words, there's no CSF to be seen anywhere, to me that is very abnormal. And if the other thing I often see associated with that is a bit of hyperechogenicity in the thalamus on the ultrasound. That combination is much more concerning, and you can see it in the preterm as well, but we often don't talk about it in the preterm. Okay, now see what you think for this. You know, she's got a prominent cephalohematoma from a vacuum extraction. She's quiet, a little bit encephalopathic. Would you order a CT scan? The current American Academy of Neurology recommendations still stand from Laura Ment's paper that said that if you have concern for any hemorrhage that could be contributing to encephalopathy, that you should get a CT scan. Would you get a CT scan? No. Does this alter anything you want to do with this baby?
We still have a problem with what you called quiet. But I would try and see, well, in our unit, if a baby is too quiet, we would put him on neuromonitoring, which means at least AEG to see how she's doing.
So you do that over this big cephalohematoma?
I wouldn't put anything on the big cephalohematoma, of course. I try to find a place without a cephalohematoma, even if it is not the right places to put electrodes.
So you're mainly just looking for amplitudes and cyclicity?
To see if the babies also have some abnormality in their brain function.
So this baby doesn't get hypothermia treatment. You think the baby is a little bit mildly encephalopathic, but slowly gets better, and
it really depends on the neuromonitoring. If we see that she has some kind of depression, we might, up to 6 hours, if the AEG will be still depressed, she might get, she will definitely get hypothermia.
And if she doesn't get hypothermia, would they get an MRI scan? If they do get hypothermia, I presume in most units in Israel they would get an MRI scan? Would that be
not
true?
all hospitals and NICUs have MRI.
But they'll offer cooling even without an MRI scanner?
Yeah. They offer cooling in all the units, but not all of them are able to do an MRI scan, even if they have an MRI in the hospital.
So you know the AAP criteria said that cooling should not be offered in centres that can't offer.
In America.
They were the recommendations from all of the international trials, though, that they should be undertaken in specialised centres where EEG can be offered, where neurology should be present, and where an MRI scan should be undertaken. And what they encouraged was that centres transported to specialised centres. I'm just being provocative.
No,
But
for us it is the transporting would not be as maybe professional or experienced as in other places. And we believe that starting cooling early on is more important than transporting. I think that's the thing. The goal is to get the cooling system working as early as possible.
It's a separate discussion that's not for now, but transporting babies in this country is extremely complicated for economic, logistic, political reasons, and so, you know, it's easier to give when we can tell you about that some other time, but you know, it's easier to give hypothermia and then transport the baby later for an MRI.
right, and so would that be offered to centres that don't have an MRI, that they would send the baby to another centre as an outpatient?
No, Meir does not have a lot of Barzilai.
I think that most centers today, when they cool, they will do an MRI.
Yes.
This is my own feeling. I mean, most of the big hospitals will do it. Once you cool the baby, eventually will do an
The
MRI.
question is the smaller hospitals.
My center, between day 4 to 10, 7, something like that, will do the MRI.
Just I would like to go back a little. Does the mother take any medications is the child hypoglycemic or something like this?
Yeah.
Some history is my
Yeah, the mother is she's actually visiting from America, and she takes 2 different SSRIs. So
Very common.
Okay. Now the other question is it encephalhematoma or subgallal hemorrhage?
so the baby appears hemodynamically stable, and it is confined within the suture lines.
So we have SSRI and we have to wait.
No, that was my question. If it's subgallal and cooling, I a little bit hesitate. It's always the question. Of course, if it's moderate, but if it's mild and subgallal, cooling has its effect.
Yeah, so that's a really interesting question. I mean, we used to worry that, I mean, I can give you a different example. You do your ultrasound at 2 hours of age, and this is a baby who's got moderate encephalopathy, and you want to cool, and you see a large parenchymal hemorrhage. You know, are you going to cool? So there's 2 schools of thought. It's a little bit like the pulmonary hypertension thought. You know, like people talk about, does cooling make pulmonary hypertension worse? Well, probably it does a little bit, actually, probably through cold stress mechanisms. We know there's a 30% higher risk of pulmonary hypertension in babies in the randomised trials.
And the SSRI of the mother also.
And the SSRI of the mother, two SSRIs, increases the baby's risk of pulmonary hypertension. But you can treat pulmonary hypertension, right, with inhaled nitric oxide, and you cannot have to not treat the brain. So you treat the 2 conditions together. So what you do in the setting of hemorrhage, in my setting, is you treat as though you would treat for the hemorrhage, right? So you're monitoring in terms of hemoglobin and making sure that you've got no GIC and no other coagulopathy, as you would even in a multi-system affected bad HIE baby, and you protect the brain.
I think also that all the randomized controlled trials did not show that the babies that were cooled had worse bleeding,
No.
coagulation than the controls. They all had.
No, I tell you what happens though is we're more nervous. So there are more babies who have a platelet count just below 100. That has been shown to be the case. But what really happens is we transfuse them all because we're nervous. So there are many, many more platelet transfusions given in the setting of cooling than were given in the babies that weren't cooled because we get nervous. So we like to.
I think that we would cool the babies if there was a bleed, because I wouldn't think that the cooling would worsen the
If there is a bleed, why would we
hemorrhage.
cool?
Well, no, it could be a hemorrhagic conversion of an ischemic injury. So you will get, you know, hemorrhagic. I mean, it can be tricky. We had a very recent baby who, and we've had 2 of these recently, and maybe you see more of them, but who were midwife deliveries where they were labouring. They were both primates. They were labouring for a very, very long time, and both of them got stuck. And had to be dislodged manually for a C-section delivery, and both of them had a significant amount of trauma around the head. They probably had some deviation of the skull under. They both had multi infarcts that were hemorrhagic in nature. They probably weren't direct trauma, but were maybe venous occlusion combined with ischemia, causing some hemorrhagic conversion in areas of ischemia. And they both had a lot of seizures. We called them both, but there was discussion about it because the hemorrhages weren't, and they had some extra axial blood as well. I mean, the typical subdurals, subarachnoids, subpials, plus these hemorrhagic parenchymal lesions and a lot of seizures. But so you can see unusual combinations of, and you know that there's a traumatic component, but you also know that probably these babies were bradycardic before they were delivered, and that's why they went to the emergency C-section, because they weren't making progress and they were bradycardic, but then there's the trauma associated with the delivery. So it's not always straightforward.
If you have a discussion with yourself to cool or not to cool,
Yeah.
what direction would you take most of the time? Cooling without substantial reason, or not to cool if you don't have substantial reason?
I would say sometimes I'll seek a second opinion, because I don't always trust my own. But I clearly am more of an aggressive to call rather than not to call, because I do resonate with the fact that it's 3 days in a baby's life, and if it may give them 15 IQ points later in life, we'd rather give them that opportunity. But I discuss it with the family. I have had some unusual circumstances. I had twins not long ago, and one twin clearly reached cooling criteria, and the other one was a very, very soft call. So I spoke with the father and said, we're going to offer cooling treatment. The twin the gases were not as bad, and the baby was very mild. And he goes, wow, if you're going to call his brother, then you might as well, I would rather not be looking at him and saying, well, you're dumb because we didn't call you for like, I'm like, well, it may not be that at all. He may just going to have been, because we can't show that, but we called them both. So it was one of the first sets of twins that I've called, but it's, yeah. So you saw this data already in terms of the, this was roughly what I was showing you before about the number of babies who were called. So I won't go through it so much again. But to say that these things are important. So in your clinical practice at the moment, and maybe you are all in different practices, who requests the MRI scan? Is it the... But is it the attending who says, I would like an MRI done, the consultant, or is it the...
I think it will be a joint decision. I think, yes.
Usually, but the consultant is the one that...
Ultimately, the consultant. And then who writes the order? Who writes the actual request? Who fills in the form? You fill in the form with the clinical data about everything about the baby?
I got no ideas. I did a few days ago in a cooling case.
Yeah. So, you know, yeah.
The truth is that we get complaints from the radiologists that they don't have enough information.
Right.
I've noticed a difference here between when I worked in London. The detail used for radiology requests is far less here than in London.
Less, we write a lot about this. We write asphyxia, need MRI. This is all the information the radiologists usually get.
The system in our institute is different because we have to get the administrative.
They have to approve.
So you have to write a whole bunch of.
So what do the radiologists want? What do you want?
Information. We want the diagnosis before we see the images.
So you've got a clinical diagnosis. So it's a term, you want the gestation of the baby. Simple, do you get that?
Wait, actually.
You usually get that?
Not much.
Not much? Do you get like the cord gases, or would that be, do you get whether there was any concern for trauma or like, and what about the degree of encephalopathy or how severe the baby? Not usually. Whether the baby was cold or not.
Yeah, I think we will write this down. Would you, Leo?
It would be good.
Perhaps I think it's the most important thing to write.
I mean, I think these things are really important for them to be able to render a reasonable interpretation. When you're running blind, it would be like me showing you, I don't know, a result of a blood gas, but I'm not going to tell you anything about the clinical scenario apart from that it's a baby. You know, and then I'm going to ask you what you think, right? Because that's what you want to know. You want to know, what does the radiologist think this is? But I'm not going to tell you whether they're on a ventilator, what kind of ventilator, what their underlying diagnosis is, what I've done with them in the last 4 days. I'm just going to ask you what to do, you know. It's really hard. So they need a lot more information, and if you're giving them too much information, they'll probably tell you that there's too much information, but to be able to properly interpret the images, you're expecting a lot back from their expertise. Alternatively, the other thing that I say to radiologists that I think is really important is, you know, if you're not given the information or you're not 100% sure, now if you see, you know, if someone gives you that this baby had a bilirubin that required an exchange transfusion and you see a picture consistent with connectorus, and it's probably okay to say, I think this is consistent with connectorus. But more often than not, it's important to report the findings. So sometimes like those, and we'll look at some more, those enlarged subarachnoid spaces obviously that reported as cerebral atrophy. Well, maybe that is, but it's probably better just to say there's an enlarged extraaxial spaces and enlarged ventricles consistent with, you know, decreased volume or something, you know, because assigning cause sometimes can be hard to do, you know. Okay, so we talked about who writes the orders. Are infants in your units routinely sedated for MRI?
If he's quiet, no.
If the baby is...
If the baby is quiet, as you said, no sedation.
And we have
The wrap,
the wrap.
the papoose,
Anesthesiologist, he decides.
the anesthesiologist.
Most of the time they don't give anesthesia, but the anesthesiologist, like, you have a special bed. Come with the child inside the bed and be quiet.
I would say that until we started using the MRI, most of our babies would get sedated. And the reason would be also that because of the time slots would be so short, and we have to make sure that the baby gets the scan, and we weren't so experienced in getting them wrapped as professionally
Wrapped and packed.
as we do now. But now we are becoming, I think, thanks to Arena, more experts and we have better training, and we use the Elon's experience as well to learn how to do it without sedation. Thank you, Elon.
Yeah.
Taught you how to feed the babies before going to the MRI.
Yeah, which is the biggest
Main
problem
issue.
with the needing sedation, of course, is to sedate them. They like them to be without feeds for 4 hours. And what does any sensible baby do after being starved for 4 hours? They demand, right? Because they want to be fed. So the way things were done here this morning was absolutely beautiful. That's one of the most beautiful wraps I have seen ever. Ever. Beautiful wrap. If anybody needs, you should video your wrapping and the beautiful around the head. It was like I don't think I've ever given 100% to anybody, but this was like magic. So it should be videoed so it can be shared with everybody, because there is an art in the wrap, and it's important. It's the most important component. And then putting all the equipment on and wrapping them before you then do the feed, so that then they feed and go to sleep the way they're going to be hopefully in the scanner. And then the thing in the scanner is it makes noise. No matter which scanner you are in, it will make noise, and it will rouse the babies sometimes. And what we found even in Boston was that the techs need to get used to sometimes the fact that they'll rouse and then they'll settle, and then you can rerun the sequence. And it's okay. It doesn't mean that they're never going to settle down. There's a lot of white noise in the scanner, so, you know, it's just like going for a ride in the car, right? Sometimes when the thing that I find disturbs the babies is the stopping between the sequences. So it's just like stopping at the lights with the horrible baby in the back of the car. You stop at the lights and they start to get all squirmy again, and then you really want to drive again, right? Because when you've got those brakes, that's when they'll wake up. And the diffusion scan is by far the noisiest scan, and that's the scan that is most motion sensitive. So it's like a double-edged sword. They're the most likely to move, but it's also a pretty fast sequence. And so if you have to repeat it again, just repeat it again. Either that, or what we did at one point was we put the diffusion right up front, because if we didn't get a good diffusion and they settled down, then we could do it. But often if they're fast asleep at the front, then you could get away with it. Whereas after you get them towards the end of the scan and they're a bit warmer and a bit more sick of being in the scanner, then it can be harder to get the diffusion at the end. So you have to play around sometimes with the sequences a little bit. And you do have to optimize the sequences for whichever scanner you've got and whichever coil you've got. Because if you just expect to run them on like your pediatric sequences, they won't run well. So you really want to make sure you've optimized the sequence. The babies.
The average time for scanning in your hospital?
The average time for scanning?
Before the baby is awake in a way that...
So I would say we routinely get 45 minutes without any bother at all. Once we get out past 45 minutes, certainly over an hour is a stretch. So I have a colleague of mine who loves adding sequences, and she would have them in the scanner for 2 hours if she could, because she can think of another interesting sequence she'd like to acquire. and there's no way they'll tolerate it. After an hour, they're usually getting squirmy. So 45 minutes, we can get almost everything done that we need. So, do you think so, Srini? Is there?
That's correct. Yeah, we dedicate 2 slots for the neonatal studies because it also takes time to load and unload. And if the baby needs a little time to get settled, we'd rather not sedate them. And so if it takes, like Terry said, 10 minutes to get settled, we don't want to run out of time. So we dedicate 2 slots for that.
And at WashU, we routinely, you have to keep cleaning up. The clinical scanners, we have to keep cleaning up because I call it tech drift, because one tech will come along and she'll think, oh, if we did it this way, or a slightly thicker slice, or a slightly different TE, then I prefer it this way. And at one stage, we went down, and Bob McKinsey didn't believe me himself, but there were 52 different neonatal acquisition sequences on one of the scanners because there'd been this tech drift. So you have to keep going down and like cleaning up the scanner to make sure, and we tried to standardize the acquisition for all babies from the preterms through to 3 months of age to be a standard set of acquisitions so that it couldn't be altered, because that way we knew we were getting the same deal whether it was a research scan or a clinical scan or whatever, it was being acquired in the same way.
My question would be that regarding the last questions, we found that on our 4 babies that the more mature they are in terms of post-term, they're more, maybe they will be more, they will arouse more easily. So I don't know how you can standardize the babies from 36 weeks to 3 months. I mean, 3 months they would probably wake up much easier. And it would be more difficult to get them asleep for so long.
Yeah, it's a little more difficult, but it's still manageable. I would say up to about 12 weeks, it's pretty similar. You get grumpy babies and you get really sort of calm babies. It's sort of partly temperament. I think out of the neonatal intensive care unit, the hardest babies by far to image that I've ever had to image are term-born healthy babies in the first few days of life. Especially, we had this, we started to recognise that imaging on the same day they'd been circumcised was just a disaster, right? It sounds so simple, but we were doing it all the time on these healthy term babies. So term babies in the first few days of life, because the feed volume is not consistent and they're hungry and they're grumpy and they're having things done to them and life isn't as nice as it was. So now we actually wait for our term babies to go home and we bring them back at 2 weeks for our controls. But our preterms, I would say, you know, we always tried to do term equivalent, and the problem was the healthier babies tended to go home from the hospital earlier and the sicker babies stayed later, and the sicker babies tended to be imaged later because they were still here, and they were the grumpier babies because they're neurologically and their regulation is all shot up and they're very sensitive to noise. So I'm not sure how much it is actually gestation as it is the baby. Who goes with the baby to the scanner? Is it a non-specialised nurse? Is it a specialised nurse? Is it a medical attendant? Who goes with your babies? Medical? Medical.
We do have a specialised nurse that is going now.
Yeah. So most units can develop a specialised nurse, which is actually by far the best. We have a team now of nurses. We had a core group of 4 nurses who got our MR program really up and running, and now we have 20 nurses that are trained in AEG, NIRS and MRI. They're trained to wrap and pack, to go to the magnet. If it's a baby, we have a list of criteria that needs a medical attendant to go with the baby, then there'll be a medical attendant, either a fellow or an attending with the baby. But otherwise, these specialised nurses are by far better than anybody, and we're going to the scanner every single day. So it would be really hard to have one of us down there with the baby for an hour, and with preparing the baby, taking the baby down, bringing it back, it can be, you know, an hour and a half, 2 hours. What does your routine MR involve? T1, T2, diffusion. Do you get standardised diffusion measurements? Do you get an ADC and an anisotropy measurement in any regions of interest? MR spectroscopy, MRA, MRV.
Usually the
First
first
four.
Yes,
One of these,
Yes.
doing diffusion, we're always doing.
Yeah.
We don't get any measurements, and we usually don't do spectroscopy. And we will do an MRI or an MRV only if there is really a big hemorrhage, something
That's high
that's
risk.
very unexpected.
Yeah. So the diffusion measurements, I think, can be really helpful to start to get your head around. I think they can be really helpful because Alan Grant is actually working on this, and hopefully one day it will become very close to being online. It's nearly available online. She's developed these standardized quantitative diffusion maps that you'll be able to immediately line up your diffusion image against, and they're meant to highlight any regions that are different from what the distribution range should be for healthy term-born babies. So it would highlight for you areas to, it's really meant to just focus your attention on areas that have shown deviations from normal. We do standard diffusion measurements. We do them usually in the thalamus and the posterior limb of the internal capsule, just as standard. And then if we see any areas of restricted diffusion, we measure what the actual quantitative diffusion is in that area. And the reason we do that is because we've seen very subtle changes in these diffusion coefficients in the thalamus and the posterior limb that are hard by your visual eye to pick up. And also in the areas that we do see reduced diffusion, quantifying it has been associated with outcome. So when you see a diffusion coefficient that's, only, we know what the normative numbers are meant to be, and you get very used to what the normative numbers, and if we see that it's, significantly lower, like lower than 60% of what it should be normal, we know that's very predictive of very severe area of injury. Whereas if it's only 80% lower, then we know that, that's going to be a milder type of injury, and those have been related to outcomes.
The question is, when you see it with your naked eyes, that you see restriction, because if it's less than 60%, you will already see it as a restriction in the diffusion.
But it can be less than 40%. Do you know what I mean? It looks the same, it looks black. And when you get the actual measurement, sometimes it can be a surprise. You can see that it's 0.7, and then other times you can see it's 0.4. And to me, those numbers are different. They're telling you something about the severity of the restriction. So I just find it useful, and I think our group just brought it in, that in the regions of injury, we would always quantify it, and then we would always do the thalamus and the plic. It's pretty quick with ROIs on the, and it comes in the report. So if an injury area is identified
So
on
you get
diffusion.
both sides of the thalamus and both sides, both plics, which is a little bit difficult, tricky, because
It's pretty. It's just we just do the middle third, so it's pretty easy actually. Once you get used to doing it, it's pretty straightforward. Maybe it takes another minute or two than just looking at a normal scan, but it's. I mean, you can do it too. The neonatologist can easily do it too. Just looking at.
No, we do it sometimes, but we do it when we see that there is restriction. We say, okay, it's 600 or 400. It's really
Low.
we don't do it where we don't see any abnormalities, but what you're saying is that it's important to look, even if there are no abnormalities, to the naked eye to go and...
Well, once you get these quantitative new maps, you might find that you don't need to do that so much because there'll be an immediate comparator. But I personally think if you're imaging a baby where you're concerned there's been a significant insult, then just getting that study alone should warrant you using that study to its full extent, and that would mean getting those metrics.
Afterwards, if you could give us the reference for this.
It's not out yet.
The
The
quantitative.
numbers are not out yet. But
Oh no,
we have a-
there's normative data
Yeah,
that's out.
yeah.
There's normative data of quantitative ADCs. Yeah, there's normative data that's published. But the maps that Alan's been doing will become available as a software tool very soon. Free. It's free. Free software tool. So sequences, I can leave these. I'll leave all the slides with you guys, just the types of things that we have used in the past or tried to optimize in terms of imaging acquisition and sequences. You're welcome to use or not use any of these.
Don't you do a SWI?
We do a susceptibility weighted image. It's just not on here. It's very quick. And I have to say, although we do it, it's more confirmatory because I don't know that there's a lot we see on it that we don't already see on the T1 in particular, but we do it to confirm that some of the high intensities we see are really blood. No gadolinium. No gadolinium. So who interprets your MRI? Is it a general radiologist, a specialised paediatric radiologist, a general neuroradiologist, a specialised paediatric neuroradiologist, the neonatal team, or I actually am not sure who it is?
The general neuroradiologist.
My center pediatric radiologist.
Yeah, but you're looking at them also.
Formally, report.
No, the formal report is by the radiologist everywhere, eventually. Hopefully it's a neuroradiologist, and if we're really lucky, we have a pediatric neuroradiologist.
Is there someone in the Israeli community who has, in pediatric neuroradiologists, who has a particular interest in this area, or is that going to suddenly emerge from these new advances that are occurring?
In Tel Aviv, there is a pediatric neuroradiologist. Not my. I used to work there.
You used to work with her
Yeah.
also.
Yeah.
Liat Ben Sira.
We have a few.
Does
She
Not
trained in
very
No,
Boston.
no, Liat Ben Sira, she trained in Boston. I don't know
Yeah.
if
Liat
you were
trained
there
in
when she...
Boston.
And does she have a particular interest in neonatal imaging? Not really.
I don't know. She used to. I don't know if today, but she used to when I worked there.
Our neuroradiologist is extremely particular, has an interest for in utero MRI.
Fetal.
Fetal. And also every MRI is also looking at this.
Yeah.
Generalized neuroradiologist, but with an interest in pediatric neuroradiology. It's also true of our neighbors down there.
And I don't think it, I'm going to be bold enough to say, I don't think it really, I think each centre needs to have a person identified who is like the central person who not only reads, but the other thing that's important is whether you review the cases with the clinical team, because you learn a lot together about the clinical radiological interface when you are comparing them. I don't think the specific training road makes a difference, but as a society, I think we're still even upregulating, and it sort of has lied between pediatric radiology and neuroradiology, and of course there's more pediatric neuroradiologists in America, but still they haven't had much of an interest in this particular area, apart from only a very few across the country. But as the number of images start to upregulate, I think having some forum where things, or having some person who's in each centre, or having some, when your society gets together, some little half-hour thing or something that just talks about this and the different scoring systems, or if somebody adapts a reporting form, and we're happy to share with you the reporting form we've adapted. If someone shares with you that reporting form, sharing it so that everybody's got the same sorts of information that's being circulated. Otherwise, I think it can be really confusing for the neonatal community when everybody is doing something different. Who reports the findings of the MR to the family? Nurse practitioner, doesn't seem that is so common here. Junior medical staff in the NICU, junior medical staff in neurology, senior medical staff in the NICU, senior medical staff in neurology, or I don't know. So mainly the neonatologist.
A neurologist and a neonatologist
Together.
with a nurse in the room.
In severe cases, we would do it together, but I think on the milder cases, we would go alone. The neonatologist would go alone. Only in the most severe cases, we will have the neurologist get involved in the practice, because also we don't have, unfortunately, enough neurologists 3 times. So, and we are more in contact with the family, so it would be for them, I think, easier if we convey the findings.
Neurologists are rare species. The more you go to the south, the more rare they become.
And do you feel comfortable with transmitting the information?
I think we're relatively, I think we are comfortable. We're not comfortable in giving the bad news in general. I think that nobody is happy to give the bad news. The question is not whether I feel comfortable. I think that the correct answer would be who is the right person to give the answer to the family. And I think that we are. I think we can do it.
Because usually the answer that we get to the petition of the MRI is pretty straightforward. It's either normal or roughly normal or roughly abnormal. So in that sense, it's not much of a petition to understand from the MRI scan that we need the specialist of the neurology to understand the true meaning of the MRI. So in that sense, the MRI is pretty straightforward, and it's much more to contact the family, which we have much more than the neurology who just come to give a consultation.
I feel more comfortable with the neurology, especially when usually we have one neurologist that he's for us, so he's doing all of the cases and he's also doing the follow-up. So I like to that they will know him beforehand, and then he already know the case, and then they come to follow up. He already know the family, the history. The history is always is very much involved, which I feel much comfortable when he's there and he answers all the sometimes long-term follow-up, which I.
So when do you undertake? I know we've already discussed this a little bit. This is this term baby still. Day 1, day 3 to 4, day 6 to 7, day 10, twice during the first 2 weeks of life. What are most people doing? 7 to 10.
We will try, but not always we will have the
slot.
The slot.
Okay, we saw this earlier. What's the pattern? Pretty straightforward, diffusion weighted imaging.
This was the quiet baby?
Yeah, this baby can, actually these babies can present as being very quiet sometimes, ventilated and quiet, but very quiet. I mean, they may not have a lot of seizures always. So, the pattern.
There is watershed, I think. There's also, of course, the basal ganglia also, of course, but I think that basal ganglia are very, very bright, but also
be careful with this sort of, you can have some of this sort of effect that's not real, so they will look very carefully to see if this is artifact. But the major injury is, so an isolated deep nuclear grey matter injury involving the thalamus, the lentiform, and the most rarely injured, the head of the caudate. The head of the caudate is usually a very good control for you because it's the least likely to be involved, and so on the T1s it's usually your control. So when you see that that's gone as well, you know you've got a very profound injury. So what's the outcome for this baby? What are you going to tell these parents?
100% CP and 90% neurological damage.
Yeah. So, and the type of CP?
Quadri, no? No.
Yeah, so spastic quadriparetic CP, usually associated with chorioathetosis and high risk of epilepsy and other cognitive impairments. This baby won't feed, will most likely need gastrostomy tube.
Either way, different.
Yeah.
Usually at 4 to 7 days it's
too late. So yeah.
So
Do you withdraw?
Sorry?
Do you withdraw?
Yeah, but the problem with this is, as Elon just said, that often it's too late. If you're imaging at day 4 to 7, they will be ventilating themselves by then. Even if you take them off the ventilator, they will breathe for themselves. Okay. So this is where the early imaging can be very...
the severe cases, we do press a lot the radiology department that we want to have an MRI so we'll be able to redirect care with the parents, especially if the baby is very bad with the EEG is isoelectric, we'll go for the first and second day and do an MRI scan. It's not
Will it be the same image on the first 24 hours?
If it's severe necrosis, yes, it usually is. Because severe necrosis will produce the diffusion pattern. It's apoptosis that is more impaired. About a third of the time we saw it undercooled it a little bit, but if it's there and it's bad and the baby's bad, you've got a very flat trace that stayed flat at 24 hours. That's the time to get that kind of imaging to know what you're dealing with. Usually I will try to wait outside the first 12 hours and get it closer to 24 hours because I feel more confident that I'll see the more full evolution of the diffusion. But it depends on the radiology or the MR scanner's availability. So you know these two patterns, the basal ganglia and the watershed pattern, tend to be in different types of babies, right? So the basal ganglia lesions, still the last one I saw was actually a mother who had had an unremarkable pregnancy. She was a very healthy mother. She had some abdominal pain. She thought it was early labour. She rang in and the hospital said, yes, pack your bag and come in, but she had to find somebody to look after the dog, and she did a few other things, and she got her bag packed. She got in. As soon as she got in, there was some deep decelerations noted in the baby. So they took her for an emergency caesarean section, and when they opened her up, she had massive intraperitoneal bleeding. She'd had a massive liver AVM, which we think was probably congenital, that she'd ruptured, and had tamponaded herself within her peritoneum. But as soon as she was opened up, we lost the tamponade. She arrested. And so the baby had both compromise from her, cardiovascular compromise prior to delivery, and then a maternal arrest. And so the baby came out and was down with profound acidemia. The mother, of course, was resuscitated and went to our ICU, but was unavailable for the father, who now faced a mother who may have brain injury and nearly died, or a wife, and a baby that was, clearly we were very concerned about, didn't feel in a position to make any decisions about whether to redirect care without his wife's involvement, not knowing whether his wife would survive or not. And so that was the last time we saw this pattern, and that baby fell exactly into this profound sentinel event, very acidotic, needed a lot of resuscitation, was profoundly encephalopathic, had multi-organ dysfunction. So all of those things being said to the radiologist, who's then like, oh, this is a severe acute sentinel event with multi-organ ischemic injury, I'll be looking for this kind of pattern of deep nuclear gray matter. In contrast, the ones that we miss often are the parasagittals. And those are babies that there's a very strong association actually with maternal chorioamnionitis and fever. These are mothers who, the baby, there's a few decels, the mother may be febrile, the baby comes out, there may not have been any major concerns about the baby but until late. The cord pH is usually not so bad. You need to resuscitate, but it doesn't take much. The baby seems to perk up, but then they look a little bit hyper alert, a little bit that stunned kind of look. And you kind of think, oh yeah, I better keep an eye on this baby. Maybe I'll bring it up and put the AEG on, and the amplitudes don't look too bad. And I'll send the baby to the ward, and then the baby has his seizures at 12 hours of age and comes back down to you at that point, and you've missed this window of cooling. So these babies are much harder. They're like the stroke babies, right? The stroke babies can fly completely under the radar. They can be poor feeders. Some of these babies come down for septic workups. Somebody notices they're not feeding well, and they don't call it encephalopathy. They call it that the baby's a bit, not as active not as good a feeder as he should be, and might need a blood count and to be considered for a septic workup. Come to your triage area and you look at it and you don't think, oh, I wonder if this could be neurologically mediated. So they're much harder babies to pick up. So we talked about this in terms of the outcomes, and these being much more like kind of stroke-like lesions in terms of their outcomes. The parasagittal distribution, we increasingly find it can be quite diverse in terms of exactly where it lies, although it's mainly anterior and posterior watersheds. You can see the distribution coming in different regions here on the diffusion weighted and the ADC.
Can you comment on the involvement of the corpus callosum? Like 2 slides ago, and we see it many times. Does it mean that the injury is there for already several days?
So this injury definitely is. So the other thing that's kind of interesting is whether you see true neuronal cortical highlighting or the subcortical highlighting. So when you see this with the corpus callosum pattern, there's 2 reasons you could see the corpus callosum or the posterior limbs a bit different, because the anterior and the posterior limb to me almost always are Wallerian degeneration. I mean, they just have to be.
The optic radiation is also sometimes.
But the corpus callosum, especially if there's some white matter involvement and grey matter involvement, could be a primary injury. It could be primary injury in the white matter and the grey matter. But in this case, I think not, because in this case, if you look at what's happening, is it's underneath the cortex, right? This is lying, like, some of it might be in the cortex, but there's a lot of it that's subcortical. And what we'll next see is this area in the middle filling in a day or so later, where you'll see true Wallerian degeneration through the whole region. So if you look at the first day these kids injure, or like day 2, it's all the neurons that light up on the diffusion weighted image. It's right along the neuronal cortical surface, right? Because that is the primary area of injury. And then it only takes another 2 days, especially if they're not cooled, and you'll see the subcortical highlighting. And then by about a week, sometimes you'll see the deep white, like the axons are retracting slowly down as the Wallerian degeneration progresses. But this one, when you start to see the posterior limb and the anterior limb also alongside the corpus callosum, that's what makes me think it's more at a Wallerian stage in terms of the degeneration. So here's another border zone. Now, about half the time, these watershed or border zone infarcts are unilateral, and half the time they're bilateral. So of the times they're unilateral, which is 50% of the time, 50% of the time they're anterior and posterior, and 50% of the time they're only, so if you take it as 25% just one, 50% 2 on, or 25% 2 on one side, 25% 3 zones, and 100% 4 zones. Just sort of, to keep it simple. It's not quite that straightforward, but it's pretty close. And the most common is the posterior zones, and don't ask me why, but it's more posterior predominant than anterior predominant in terms of the impact. And for some reason, even though you're right up against the visual cortex, and sometimes you'll even see secondary degeneration in the optic radiation, we don't see a lot of visual. They move vision. They seem to be able to move vision from a rehab point of view. So I suppose because their eyes are open and they're getting stimulation all the time, there is adaptive mechanisms. So even though you worry about vision because of where it's affecting, it doesn't seem to often be the area that doesn't seem to be the impact. But there can be vision. Hey?
Early on, the peritortial is significant torticollis, and then they catch up, and somehow it disappears.
Yeah, and sometimes there's visual association things. So you'll see them, and if it goes a little bit more into the parietal, you can see early neglect if you're really careful in them, and that may be part of the torticollis because they are neglecting half of the world. So I always make sure that I turn them around so that all of the world is coming at them on their neglected side. And that's where the diagnosis and the impact of having therapy or rehab right from the start can really help. But the torticollis may be a secondary sign of that neglect. So what do you see here? So this is T1, these are T1 weighted images, and this is day of life 5 after this baby, encephalopathic baby, received hypothermia therapy.
Looks like there's a highlight of the cortex.
Right. So you've got cortical highlighting, right? So you've got to learn to follow your cortex. Some people, it is called the cortical ribbon for a reason, because it's like a beautiful ribbon that's all around the outside. I explain to people sometimes, like, you know, when you're a kid and you used to have those drawings where you did the crayon on the outside and then you shaded in with the coloured pencil underneath it. Like, I think of it like that, like this is the crayon area where you were meant to draw all around the outside with the crayon. So you want to follow that crayon all the way around so that you can see all the different regions, like here, like here. Now, the base of these sulci are watershed zones. So in the immature brain, these are regions of hypoperfusion, and so they are more likely to show areas of injury than at the top of the gyri. So you have to look at those regions most carefully, because this is where you'll see the most damage. There's also damage here, right by the hippocampus. So these are regions of hypoperfusion, water zone in a way, but not the typical parasagittal. These are watershed into the base of the gyri. What are you going to say to these parents? Everyone looks at I'm not.
We're calling them neurologists to deal with it.
I would say that there is first of all probably the baby has seizures. Also, by the way, I think that there is also some evidence of edema there. I mean, the gyri look very.
Yeah, they are.
Thick.
Yeah, well, you can see here, in particular in this temporal lobe, they are almost pushed out, right? You get the appearance that you've lost a little bit of the normal gaps here, and that this is a darker colour in the white matter than, say, here, and that these temporal lobes look still very swollen. They may be swollen because there was an enormous seizure burden that could not have been controlled. We don't know. We have to wait.
About prognosis without the clinical history, but there is a good chance, I mean, there's high chance for cerebral palsy, quadriparetic type, seizures, cognitive problems.
Right.
Outcome looks poor.
So to look for the motor issues, we would look at the posterior limbs of the internal capsules here, which, remember we looked at a number of these. I like seeing them on the coronals rather than the axials. I just find it easier to follow them down from the motor cortex all the way down. And if you are, the way I often say to people is, imagine this is like the two strong ropes of a swing, and you're going to be sitting on the base of the swing here. Are you feeling confident as you swing that these ropes are going to hold you? No, right? There's interruptions, they look kind of interrupted and scraggy. It looks like a very old swing where the ropes have kind of untangled a bit. So I would say these are impaired. They're still present, but they're very impaired, so it would be very concerning. We talked about these evolutions in terms of diffusion, which can be negative, as in not always uniformly negative. The timing that you see most of the alterations, and then the evolution for T1 and T2 changes, and to be careful about Wallerian degeneration. I've had people sometimes report that if they do an image on day 9 and there is acute diffusion changes, that these are indicative of acute injury in the last 2 to 4 days. And of course, it's all Wallerian degeneration, which I'm sure none of the radiologists here would make the mistake of saying. And then obviously atrophy. So we find the spectroscopy actually really helpful in telling a story. I see like people split. I see the spectroscopy believers and the spectroscopy non-believers whenever I am interpreting this, and that does spectroscopy add a lot. I personally find it helps when I'm looking at it.
Depends where you do the spectroscopy. I mean, do you do it on basal ganglia, or you do it in other?
So we routinely do it on the thalamus in the left hemisphere only, and we do it, that's our kind of our standard for all our high risk, especially HIE babies, and then we do it over any area of injury. So if there's no other area of injury, we always have one standard voxel over the basal ganglia. And we only ever do a 144, and if you see something that you're not sure if it's lactate or not, then they can invert it to C at 288. It gives us additional information, particularly, as I showed you on that other picture, if you see the lactate there and the NAA being nice and robust, and then a week later the NAA is down, the lactate is normalised, but it tells you there's been neuronal loss. Obviously, here is a baby who was imaged in the first 12 hours of life, and these are old images obviously, but what do you see on these images? So this is all supratentorial. So all is highlighting, right? Very, very marked highlighting right through the cortex. Lot of swelling. Right. So I don't know. I mean, if you image really early like this and you see this profound a picture in a baby, it's pretty hard for me to believe it only happened exactly at the time of birth. Obviously, you'd put it in the picture, but we would normally see this sort of change more at day 2 to 4 after injury than we would in the first 12 hours of life. So that's sometimes why we hope that having a magnet right in your unit, if you can put them in the magnet, then, I mean, you can prevent a lot of adverse findings. The last large lawsuit in the United States that I wasn't directly involved in but was settled in our hospital system was for $16 million against the obstetric team. So these are extraordinarily expensive cases. How many of you routinely perform MRIs in your preterm infants at the moment at term equivalent? Not. Leading the way. Is there any clinical scenario you would perform an MRI in a preterm infant?
I think we would do it.
On the crane.
He seems to be very impaired on the day of discharge. That will ask to see.
So if the neuro exam is very abnormal.
Before we put a VP shunt.
Before a VP shunt?
I think that for procedures, before neurosurgical procedures of any kind or any procedure.
So how do you decide when to put your shunt in?
Oh my God. I mean,
when your neurosurgeon says they will do?
No, when we tell the neurosurgeon you will do it, but it's...
you're lucky. You're lucky.
We do the Levine
Can we
index.
have your neurosurgeon?
We measure the Levine index, and this is I think this is the way we do it. We don't look at the head size, the vent size.
And so it's frontal horn plus 4, is that what you're doing?
Yes, we do it before. I mean, not the shunt. We start to do the LPs, and then we do the external ventricular drainage. And once it is, we can't anymore after something like 3 or 4 EVDs. We don't do subgaleal shunts in my center at least. And then we go for a shunt.
Interesting.
But they're fair because we put a reservoir. You do an EVD, which is one of the only 2 places in Israel where you do it. And so
in terms of taking these premature babies, especially the very premature babies, it can take a lot of equipment and a lot of preparation time. You may need an MR compatible isolate if you take them down before term, an infant head coil, monitoring equipment, the VAC fix device. Here is us, preparing a baby with the papoose. And our sequences standard there are T1, T2, T2 star, diffusion, and spectroscopy we sometimes do and sometimes don't. We look a lot at folding, sulsation, myelination, growth, and injury. Because this is a period of very rapid brain development. As you can see, you can go from the extremely smooth preterm brain through to this very folded brain. What do people think? This is a term equivalent MRI. How would you look at sulsation in this in terms of folding? What kind of landmarks? Well, first of all, do people think this looks like a well-folded term brain? No, not really.
Look at the ventricles first, that are enlarged.
So you have enlarged ventricles, right? And you have some of this darker outlining, which may represent old blood. It's hard to know.
Dark matter.
What would you expect at term equivalent? I mean, ideally you'd want to go up and down some folds, but what kinds of sulcation should you be starting to see? 209. You should be starting to see some, not just prime. Most of these look like, there's maybe some secondary folds in here, but most of these just look like simple primary folds, right? And at least you should be seeing a number of secondary, which you might be seeing in here. But one of the areas that's always good to look at, one of the most mature areas is the visual cortex, right? In this area here. And you should be starting to see, if not secondary, at least ideally tertiary folding. So by that I mean you should have to take 3 turns, right, when you go from the surface. So primary, I just go once, one direction only. I can't even find you a secondary fold in this baby. But I should go in, up, and back. I should take 3 turns. And I should be doing that around here in this medial occipital cortex. So again, you're trying to go and assess brains from simple to more complex. So here's one, look. Here you go. See this? I'm much happier in this brain. So this area here is much, much easier to see that although we have, and we see this in our preterms, these slightly disturbed, very long primary when they should be more complex secondary folds. But you do start to see a lot more complex folding in this brain that's more reassuring to me. The frontal lobe is still going to be very simplistic in terms of the nature of the folds. But this occipital region is really nice to look at. The posterior limb of the internal capsule we've already talked about, particularly by term equivalent, you're going to want to see good folding, good myelination in terms of the hyperintensity coming up here against the rest of the basal ganglia and looking for that. It's hard to see on the T2, it really is. It's much, much easier to see on the T1. As we said in the earlier talk, I really like the measurement of the biparietal width on the coronal T2 at the area of the cochlears bilaterally. And you can see the circle of Willis coming up through here. You see this baby had a little germinal matrix hemorrhage. But you can measure this width, and we have very nice scales that we showed for adding that in. You can measure the maximal distance, not within the gyri at the sulci, between the 2 hemispheres. And you'll see a lot of these patterns. We saw one in one of your babies today, where you see this increased interhemispheric distance. I think that baby's being imaged on tomorrow. Tomorrow here. Yeah. Term equivalent. So
it should be less than 4.
Less than 4.
From side to side.
Correct. And an area.
You can also see in an ultrasound scan very easily, I think.
So you can whichever way you do it, you just need to have it so that you're in plane. So you need to have it directly as you drop in plane, so that you know that you're aligned, which is what you can know when you can line the 2 sides up. It's usually associated with this increased extraaxial space, including the increased space between the skull and the brain, and often with these simplistic looking sulcal patterns. You can look for these punctate white matter lesions here. We actually don't know what the underlying pathology of these is. Acutely, if the baby is only a few days old, we believe, and you can sometimes confirm on susceptibility weighted imaging, that they are hemorrhages. But when you're seeing them out now 12 or 14 or 16 weeks after birth, you have to believe they're probably gliosis, because they are present there. They're often easiest to see around 34 to 38 weeks, and then they start to fade as the kids get out to 44 weeks and beyond for some reason, whether they are being eaten up in some way by other types of white cells. They often lie in the line of the posterior limb of the internal capsule, like there's some maturational vulnerability to the cell type that was just there that causes more scarring there. But often I'll be following the plick up and bang, you'll run straight into one, which seems they often will be like a periventricular sort of run. If the scarring becomes more profound, you'll see this linear hyperintensity, which is what this baby today had. And obviously the most severe form, which is very rare now, is cystic PVL. I don't know how much cystic PVL you see, but we have recently had a case in the setting of neck. We'll just about only see it now in the setting of neck because we have almost no other sepsis. So it's obviously been associated in the setting of other viral illnesses like parachiovirus and rotavirus. But it's almost always an inflammatory mediated injury now.
I have now a baby after it's a pregnancy with twins and with TTTS, and one twin is a treated fetal death, and the other twin now has cystic PVL, very diffuse.
This is this diffuse high intensity white matter signal, which we've shown is of no real significance. Here's IVH low grade, but you can look at the rest of this brain and see the increased interhemispheric distance, the increased subarachnoid space, the poor sulsation, the enlarged ventricles, including the enlarged temporal horns. High grade IVH with ventricular dilatation. Again, look at the very immature, this baby was about 35 weeks at this very immature sulsation. Post-hemorrhagic hydrocephalus. Now, even though these ventricles are very large, right, there is still a little room in the extraaxial space. So does that mean that this is critical hydrocephalus that should be drained? And this is where it can be useful either by ultrasound to look at as much the extraaxial space as it is the ventricular size, because sometimes this can be atrophy, loss of volume rather than just hydrocephalus. Cerebellar hemorrhages, here is where the cerebellar germinal matrix lies. So this is the place that you will often see the rupture, just along this lateral mid-level border, because this is exactly where the immature cerebellar germinal matrix lies. Okay, so what do you see here? This is your turn. This is a preterm 28-weeker who was imaged at term equivalent. Right, so you can see these small punctate white matter lesions, and this would actually be graded if there was a presence of a bit of ventricular dilatation, which it looks like there is, probably as moderate white matter abnormalities. But the rest of the cerebellum looks a good size. It looks like the brain is filling the head, and the sulsation looks pretty good. So, I mean, you would assess that on other images. So this would fall into the mild to moderate white matter injury only, which has some prognostic significance in terms of some mild impairments, but would not put the baby at high risk. Unlike this baby, what do you see here? So you see pretty significant widespread dilatation of the ventricles, right? Looks like this was probably parenchymal venous hemorrhagic infarct, right? Because you've got a secondary sort of hemorrhagic looking region. So this is probably porencephalic and collapse of the previous region. You've got abnormal looking white matter everywhere, and very simple, and not a lot of white matter, right? A lot of the white matter is not present, and you've got a lot of ex vacuo, increased subarachnoid spaces. You can tell this is going to be above 4, right? So multiple risk factors of a focal injury in terms of a hemorrhagic stroke. Post-hemorrhagic hydrocephalus, which I would argue at the moment does not look like it needs draining because you've got quite a lot of extraaxial space, but you've got a lot of parenchymal loss for this baby. The thalami on this side looks completely shot as well, and so this baby is very likely to have an asymmetric but significant cerebral palsy, cognitive deficits, and will have a persisting risk for seizures as well. What about this baby? This is a much more posterior view, I know. What do you see in this baby? Term equivalent MRI. Are the ventricles normal size?
Ventriculomegaly. I think diffuse changes in the white matter.
The white matter is a little bright.
And also the cortex looks immature for a term equivalent.
He might make 4 millimeters, but he's not quite as bad as the last one we saw. The white matter volume doesn't look too bad, so you'd want to look around the rest of the brain. In the cerebellum, I'd have a very careful look through because you can see these little heterogeneities in the signal, so you want to have a look through the cerebellum very carefully as well. What's this? This is another term equivalent. This is your 24-weeker that you've currently been caring for now for 16 weeks, who had his spontaneous intestinal perforation in his duct, and you're now imaging her at term equivalent. So what's this brain look like? What is this?
Looks like brain atrophy.
Simplistic gyra, a lot of ex-vapor. And I think I'm not sure, maybe the basal ganglia are a little bit hyper-intense.
So these basal ganglia just look a little bit small to me. I don't know how to describe this sign because I don't know what it is, but you see, the cavum septum pellucidum is still present. We see this in some of our most immature babies. The thalami seem to part. That's like there's been loss of volume in the thalami, and part of the thing you see is this. You start to see the bottom underneath them when they should be like this big, continuous. And you see this parting between the thalami. They just look small. They look smaller relative to the rest of the brain than they should, but clearly you can drive, sometimes I talk inappropriately about what size vehicle I can drive between the hemispheres, whether it's like a tiny small mini or nothing at all, or a little pickup truck, or I think this could be one of those 18-wheel trucks that you see on the highway that could go between these two hemispheres. There's so much space between there. So a lot of room for growth. And some of this cortex, to me, also looks a little bit abnormal in its signal characteristic. I don't know whether these could be small areas of heterotopias or different types of, you'd want to look really carefully. But we think that there's a lot more disturbance in this particular area and also going down into the temporal and insular regions than we've previously recognized. We don't know what the neurobiology or pathology is, but there's a lot of disturbances in normal cortical formation in those regions. And it's really present around this insular region and into the top of the superior temporal sulcus, sort of this region. And then sometimes even the hippocampi, you can see increased space where it should be occupied by a good-sized hippocampus. So these are all the things we need to be thinking about moving forward. What is this disorder? What would you call this brain? Has it got white matter injury? Not really. Has it got IVH? No, you never had an IVH. No cerebellar hemorrhage. So what is this?
Simple brain.
So it never grew. I mean, you never it was. So the term that we're coining is the encephalopathy of prematurity, EOP. We don't know what it means. We don't know what it is. We think it's a dysmaturation, but we can't neuropathologically, biologically fully define it. Of course, Dr. Volpe believes a lot of it is mediated by the abnormalities in the white matter, which have caused an alteration in connectivity and then subsequent effects on cortical development.
Have you followed this child up? What happens?
So what happens to these children? So this is the typical pattern you'd see in the 22 to 25 weeker. And in the boys, they do extremely poorly, universally almost, with impaired language, a lot of hyperactivity, attention deficit disorder, and an impairment in social responsiveness. So high risk for, and it's not typical autism because they don't have a lot of the stereotypic autistic behaviours, but they have the difficulty in social interactions and reading expressions and interpreting social expressions, and they have the language impairment, and the combination puts them, you know, they get diagnosed with autistic-like. Yeah.
An EEG would be interesting in such a baby, full EEG.
Yeah, it usually shows dysmaturity. It shows a very immature pattern. In girls, it's much more variable, right? And I don't understand why, but a girl can have a pattern like this and still turn out okay. And they can be, I've had twins who've had the same pattern in the same home environment, often with they are very sensitive to two things: nutrition, I believe, particularly in the first year of life, and the home environment. And the amount of, I mean, this brain can benefit greatly, I believe, from rehabilitation and early intervention, particularly around regulation and being able to recover. They often are very sensitive to sensory input, so they're the types of kids when you touch them and wrap them and do things with them, they're really, so they're very sensitive to trying to deal with their regulation and their developmental cyclicity and all those sorts of neurobehavioural domains.
Is the volume loss sustained over serial scans in years to come?
Do they have later?
So we've followed these kids up, yes, and we've followed them up and scanned them now at 7 and at 13, and we're just about to scan them at 18. I will tell you the one thing I am worried about in these kids is that the disturbances in the temporal lobe and the hippocampus in particular are going to make them very vulnerable to ageing. And I worry that we're setting up an underpinning of sort of a vulnerability to ageing for their brains. But we don't know that yet. But it stays.
You mean like early dementia?
Yeah. Yeah, because they lost 40% of their hippocampal volume relative to term equivalent, and the abnormalities in terms of volume loss and folding abnormalities in the temporal lobe are exactly the same regions that are present in people who go through early dementia or advanced familial genetic dementia. So these regions that have decreased volume stay decreased. They stay decreased right through. We're just trying to put together a Lancet Neurology review paper, bringing together all our cohort data, because it doesn't matter whether you're born in New Zealand, Australia, St. Louis or Boston, you show the same vulnerability in the same regions, and it's present at term equivalent, so it's in our hands what we're doing that affects this, and it persists right through life. And it has consequences in terms of the social responsiveness, language, and cognitive performance in particular. And that is the paradigm. And the only other area that we're just getting into is the behavioural paradigm, now that we've got the kids old enough to look at anxiety and depression, which is also more prevalent in these kids. The good news is we don't produce criminals. It's actually associated with a reduction in risk taking. So although they've got attention deficit, they're not risk takers, and so they're less likely to end up in the penal system, despite the social disadvantage that some of them have come from, which is the good news. But it would be great if, you know, the underpinnings of this appear, I believe, our data would support are related to experiences in the NICU in terms of painful procedures and lack of nurturing, and lack of other, like auditory positive human voice versus alarm noises, mother's smell, taste, touch, you know, all the things that are missing when we put them in the box, and the presence of painful, noxious stimuli, and malnutrition. So, you know, I joke, I don't joke, but I mean, Michael Meaney, you know, has shown very clearly, you take a little baby animal mouse away from the mother, put them in a place where you do nasty things to them and don't feed them well and nurture them, then bad things happen. And unfortunately, I think that's our current paradigm until we can shift our paradigm towards that. But this I think is some combination of dysmaturation associated with experience and malnutrition associated with probably some loss of connectivity. But encephalopathy of prematurity is probably the best name we have. What about this guy? He's the same, he's going home the next day. He was born at 27 weeks. How do you think his brain looks? So just teach yourself to walk around it, have a look at the folding. It's okay, right? It looks pretty okay. His brain is filling his skull. It's a good start, right? You know, we like that. I tell you, when I've seen the Swedish brains, I would be having your premature baby in Sweden because their brains all seem to fill their skulls and they have really, really nice looking brains. But there's no punctate lesions that we see in the white matter. There's no other hemorrhage. The white matter looks pretty uniform. The folding doesn't look too bad. You'd be... We haven't, it's a T2, yeah, I'd have to look on.
Good size of the basal ganglia.
Yeah, good size of the basal ganglia. We're feeling pretty positive about this guy, right?
Where's the catch?
No catch. So for us, we perform a lot of term equivalent MRIs, of course, and we particularly perform them with any concerns on ultrasound or a complicated NICU course. And early MRs we base on a case-by-case basis. Results of all the scans are reviewed during coordinated family meetings, and we show the families the scans so they can actually see what we're looking at, because it's really helpful to them to understand. When we say words like hemorrhage, they immediately think it's everywhere, right? And if you can just show them, here's the small amount of blood we're talking about in the setting of the whole rest of the brain, it really, really helps them.